Hello, thank you for tuning in to this episode. In this video, I talked to Professor Glenda Gray. Professor Gray has done a lot of work around healthcare activism, basic scientific research, clinical work, as well as held a number of key leadership positions within the healthcare sector in South Africa. For example, until recently, she was the CEO and president of the South African Medical Research Council. She, as I've said before, has done a lot of work around the fight against HIV in South Africa. Specifically, during her early days as a doctor, she did a lot of work to prevent mother-to-child transmissions, as well as was also part of the group of people that successfully took the government under the then President Thabo Mbeki to court, eventually leading to the successful rollout of antiretrovirals to treat people living with HIV in South Africa. This is a part of her life that she does touch upon in this video and many other things. I hope you enjoy it as much as I did enjoy recording it. And of course, I would have failed to fulfill my duties as a YouTuber if I didn't ask you to smash that subscribe button, like this video, leave your comments about what you think about this video down in the comment section below, and finally, share this video with anyone you think might like, enjoy, or benefit from this video. Cheers. Good afternoon, Professor Glenda Gray. To say I'm excited to have you here would really be an understatement, and I appreciate you for slotting me into your very busy schedule. You're welcome to the platform.
And thank you, and it's lovely to be talking to another fellow South African.
Yeah, though there are quite a number of them in the UK. So for anyone who doesn't know you, so you are quite a popular name within the medical research sort of fraternity in South Africa. But for anyone who doesn't know you, may please let us know who you are, where you were born and grew up, and what do you think are the kind of circumstances or experiences that influenced you to do the work that you currently do?
Sure. Okay, so my name is Glenda Gray. Trained as a doctor at Wits University. I grew up in Boksburg. In fact, in a whole lot of places on the East Rand. My father was a miner, and so we spent a lot of time on the East Rand and in mining districts across the country. So I grew up in a relatively poor household. I know what it's, 6 children. My father died when we were quite young, and my mother had to look after 6 children. And at that stage, a lot of us were at high school, and so there was a big struggle about wondering whether we would be able to go to university. We were, as young children growing up, I know what it's like to be poor and to be part of a feeding scheme at school, and also to run out of money in the middle of the month and have to buy food on credit. So I came from a family that knew the importance of education and knew that the only way one could really improve their lot in life was to get educated. And so even though we were poor, there was a lot of emphasis placed on getting good marks at school and going to university. And so I always wanted to be a doctor. I don't know why. It kind of, everybody used to laugh at me at school because at my school, no one became doctors. If you were clever, you became a teacher. And so I was, we can count the number of people who became doctors in the time I was at my school on one hand. And I think 2 of them were in my, it was me and another person in my class. And then, it's quite a rare event at that stage. Maybe it's more common, but I went to Boksburg High School, which is a government school. I also, because it was a government school, we never had good maths and science teachers. So when I first went to Wits University in my first year, I almost failed because there was this huge gap in my knowledge. It took me a while to catch up to my class. And so I can also understand the kind of, sometimes the need to bridge kids from schools that weren't as good as private schools. But anyway, be that as it may, once I caught up, I overtook them. So I was quite lucky that once I understood, how it happens at university, and once I understood how to study and, align myself to university living, I managed to then do well at university, and then really become an academic. So I guess that's my start at as a doctor. I've got a good feel, about humanity, and particularly in South Africa, and growing, and most of my training was at Baragwanath Hospital, and so I was faced most of the time with at that stage malnutrition and diseases of poverty, and then HIV. So I didn't ever think I would become a scientist. I thought science was for clever people, and I wanted to be a doctor at Baragwanath Hospital and look after babies in the ward and train future doctors. But then HIV exploded in my face as a young doctor at Baragwanath Hospital, and very soon the hospital was filling up. Every third child was HIV infected. They were small babies. The mothers were young, and this was their first baby. And our job at that stage was just to tell them, that their baby was infected with HIV. They were living with HIV, and there was no treatment. And it was just a terrible time to be a pediatrician or a doctor in the country. And so because of that, and I also came from during medical school, the nice thing about Wits was it politicized you. And so I was politicized as a medical student. I worked in the detainee support, parents detainee supports committee, where we would, when people came out of detention, we would document the injuries, get take a history about the abuse. And so I was very early on politicized, and I worked in the progressive health sectors as an activist. And so when HIV happened, I had the activism of being a doctor under apartheid, and the grounding about the need to do things that are going to change the lives of South Africans. So my first, so my entry into science was directed from activism and a need to change, to make an impact, to do something different. And so when I started to do clinical research, and it was in the area of preventing mother-to-child transmission, I very quickly learned the power of science, the power of evidence, and the power of data. And this power of evidence and power of data helped us change policy in the country, helped us take the government to court to make them give antiretrovirals to pregnant women to prevent transmission. And so I already saw, as if you want to be a good activist, you should be a good scientist, because you can use all your evidence to change the world, to fight with governments, and to make sure that policies change for the better of people. So I guess that's the beginning of my career as a scientist, was really much, responding to the pandemic in front of me, the devastation that HIV was for a young woman having her first baby. And so my foray into science was really about trying to make a difference and trying to alleviate the transmission from mother to child. So that's how I started as a scientist.
Yeah. Well, thank you so much for that well-wind groundwork. And it really does, I think, set up the groundwork for the rest of the interview. Some of the things you touched upon are things I'm going to ask you more about. Which the first one being, could you please tell us more about those experiences, right, and raising awareness about HIV, and specifically about preventing it during those early days? I suppose what I'm interested in is understanding, how we navigated the complexity and also the uncertainty that must have been inherent during that time when people didn't really quite understand HIV, right? But you knew, of course, that you wanted to make an impact and, get better outcomes for people. But How were those early days?
So when I started to be involved in AIDS activism, it was just towards the end of apartheid, and the apartheid government had set the scene for HIV taking off in our country. So racial colonization and apartheid segregation, homelands, migrant labor, single-sex hostels had set the scene for HIV to take off in our country. And that was coupled with very little information around HIV in those days, and a kind of making and not giving information properly to people who were at risk for HIV, like black hemophiliacs. And so basically, so we know that HIV is transmitted through blood products, and so the apartheid government didn't let black hemophiliacs know that they were infected. And so there was one place where HIV transmission could take place, and then the kind of labor and migrant system that we set up was a fertile ground for HIV to proliferate in our country. And then post-democracy, there was a lot of work to be done. And so in the first phase of post-democracy, HIV was not largely neglected because there were other focuses. And then when Thabo and Mbeki came into power, there was this era of AIDS denialism. And so I guess I was an activist in all this time because we were living through these governments that were doing nothing about HIV. And so I was part of a health worker group called the Health Workers Association. It helped set up NIHAWU. And so we worked with NIHAWU and HWA. And so I was on the education desk and then on the AIDS desk. And in the Health Workers Association, my job was to use HIV to kind of mobilize communities. And I'd work with a lot of people in Soweto mobilizing the youth around HIV. So I guess that's how my activism started. And I, there were a lot of activist organizations at that stage. The AIDS Law the AIDS Law Project did a lot of policy work, legal work, and advocacy around HIV. So I guess I was well grounded in the kind of the politics of HIV, which set up my feeling when I became a doctor and having to face HIV as a clinician. It kind of grounded me in the kind of societal issues we faced because of our past and our present. And so I guess that's how I felt compelled to do something, because it was my job as a pediatrician to save babies' lives. And all I was doing now was trying to give them a little bit of oxygen or some antibiotics, and they were going to be dying in their first year of life. So it was a time where there was a lot of you felt a lot of the devastation of people who were living with HIV. They didn't have access to treatment, and they were fairly desperate. Unfortunately, at that same time, the Medical Research Council has been involved in documenting deaths throughout time, and so they could tell the government that the death rate was changing in South Africa, and that we were seeing a new kind of death rate that were young. There was more deaths happening in young women than happening in old women, and that was the evidence we used to show the denialist government that this is the evidence. Yeah, these are the bodies that aren't lying, and we could show that that something was changing in our country, and it was because of HIV. So I kind of guess that's what grounded me in the work that I did. And obviously, as I got more into science, it took me further and further away from the clinic. But those kind of I was well grounded in a socio-political context that has guided my research throughout the ages.
Yeah. You also mentioned there in that response the sort of tragedy of the first response of the South African government to HIV, which was the AIDS denial. And my understanding of that was really the denial of the fact that AIDS was a result of HIV. What do you think was the cause of that denial? Was it just mere confusion, if it was confusion, or was there people were just sincerely misinformed about this, or were there other reasons to understand that period in South Africa?
Yeah, I think that one got stuck in the Koch's postulate, around can a virus cause a syndrome, and it got stuck in the semantics of what is a syndrome and what is a virus, and because so HIV is a retrovirus. It infects cells, and by infecting cells, it affects the immune cells of our body, and because your immune cells are going down, you get more susceptible to opportunistic infections, and so you have a high viral load, low CD4 counts, and that makes you susceptible to cancers and other infections like Kaposi and pneumocystis. And so I guess the direct correlation from the virus to the full-blown AIDS, if you're getting down to semantics, you could go down a path that took you, down the rabbit warren. But the issue is that whether you were rich or poor, malnourished or well nourished, whether you were living in Soweto or Sandton, the virus would affect you in the same way, and which then dispelled the idea that this was due to malnutrition, or it was due to selenium deficiency, because of the common denominator amongst all people who were getting HIV was that they had a virus, and that was causing the symptoms that they had. So I guess people got into semantics. There's also a lot of people that felt that the pharmaceutical companies was making money, and it was a kind of either a CIA threat or a pharmaceutical endeavor to make the African continent dependent upon big pharma. So there were all the conspiracy theories that always go along with these kind of denialism. And then obviously sometimes you have incredibly clever people who get down into these murky discussions, and then you can easily, when you're sitting on with the feeling of a philosopher or the feeling as a doctor, you may take different paths. So I guess there was a denialism is fueled by lots of things, and and I guess for a smart person getting into the esoterics of definitions, you could get misled. However, the evidence was there in front of you. We had people dying like never before, and you couldn't ignore the way that there was this hourglass effect. Usually in countries, young people die and old people die, and people in your 30s and 40s don't die. And in South Africa, we were seeing an hourglass where actually people in their 20s and 30s should not be dying. And so something was killing South Africans. And it was, and it could only have been HIV at that rate. And, we were seeing, we saw in that period of denialism around, 350,000 people die of HIV.
Yeah. Well, I suppose, I don't know what you think then. What's the best kind of response for a doctor? Maybe a doctor is supposed to be a sort of action-oriented kind of person. Not that they don't think, but, they don't lead with that sort of esoteric philosophizing.
Yeah, I think, basically, but when you're a doctor and you're at the coalface, and, you've worked in a ward before HIV, and you see the transition. When I first started, when I was a young doctor, every time there was a child who had HIV, it was a rare event. They would call everybody would come around the bed, and, the case, the child with HIV would be presented as an exotic disease. And, so this happened, and then eventually that it was no longer rare. And eventually this, it's every third child. And so you could see as we became pediatricians that something was changing in our wards. And it was like nothing we had seen before. And, it wasn't kwashiorkor, it wasn't marasmus, it wasn't malnutrition. It was something new. And so I guess as a doctor, and I guess how you feel if when you were in China and suddenly this unexplained pneumonia starts to happen, in front of your eyes, something is changing that you can't explain. And so that's the same way we had felt. I mean, obviously we'd seen it, we as students, we'd heard about the epidemic in the US, we'd heard about the epidemic in the rest of Africa, but we were fairly isolated at that stage. And so it took a while for it to be manifested in South Africa.
Yeah. I don't know if you have thought about and worked in trying to understand. I've read some books about how now as human beings we are sort of encroaching more on wildlife, and that increases the chances of spillover events, and that would probably increase the chances of us having pandemics. For example, the COVID-19 we've had a few years ago. Do you think this is a reasonable hypothesis that this is something that is happening, and what can we do to sort of prepare ourselves better for pandemics like COVID-19, for example?
So we will see more and more pandemics over the years because of climate change. So climate changes the rain, changes the vegetation of areas, and you will see with climate change be exposure to more pathogens, or pathogens that you never found, like malaria in New York, for instance, or West Nile in Johannesburg. So we may find viruses that we don't expect in certain parts of the world, but because of climate change, we find these outbreaks. So we will see more outbreaks of various viral pathogens, like cholera, for example. So there's the issue of climate change, which definitely will impact on planetary health. And then there's the encroachment, as you speak of, as we encroach onto forest, as we get exposed to as bats and domestic animals or cattle come into contact with each other, and they work with humans, like we see with H5N1, bird flu. We see this interaction, and this will become more and more common. And sometimes it'll lead to outbreaks. Sometimes it'll lead to little epidemics. Sometimes it'll lead to a pandemic, and sometimes we will have endemic disease like malaria occurring more commonly. So all of these things we can expect as we see climate change and deforestation and more and more encroaching onto the natural habitats of wild animals with our domestic animals. So it's something that we can expect to happen over the next 100 years.
Yeah. You are a big believer in vaccines, in the development of vaccines, specifically HIV vaccine. And one of your reasoning or motivations for doing this is that treatment as prevention cannot be the solution, since I think you said about half of in transmissions happen within, the first 5 months after infection. What is it about the virus that causes this concentrated or high infection rate within during the early stages of infection?
So I guess I can start off with saying that a lot of infection happens before you know you're HIV, that you're living with HIV, and these infections happen early on because you have in the beginning of your disease you have very high viral loads, and the higher your viral load, the more infectious you are. And so, although you might be feeling well, you have high viremia, and this viremia makes you more infectious and more likely to transmit to your sexual partners. And so, and it is treatment can work as prevention if everybody knows their HIV status and everyone is taking their treatment. But we do know that men don't interact with the health system very well. And so men are less likely to be tested. They're less likely to go to clinics, and less likely to know that they're living with HIV. And so they're less likely to go into treatment. And so one of our biggest failures as treatment, as prevention, is bringing men into treatment. And so we have more women in treatment than men. And men are less likely to know their HIV status, less likely to be on treatment, and less likely to be adherent. And so that's our first problem. So we've got to focus on getting men into care. And then if everybody who knows their status is on treatment, we can largely control a lot of transmission through that area. But there are lots of loopholes because there's no regular access to testing. There are drug stockouts, and then if you don't take your treatment properly, you're more likely to have resistant HIV, and then your virus levels go up again. So that's the issue with prevention, treatment as prevention. There are drugs that you can take, antiretrovirals, for prevention now, also long-acting, but often people who are not living with HIV feel that they don't want to take these tablets because it may stigmatize them, it may give them side effects. And the long-acting injectables that may help us control HIV are not yet readily available and are cost a fortune to do, up to R1 million a year for a woman. 2 injections a year is, R1 million. So it's clear poor countries can't afford that. And so the only way a very important tool, and the only way really to control a pandemic or an epidemic is to have a vaccine, because a vaccine you only have to give once or twice, and it induces the immune response that you need to preventing you from acquiring the disease. HIV is particularly difficult. It's a retrovirus. 8% of our human genome is made up of ancient retroviruses. We were exposed to these retroviruses 400 million years ago. We have viral fossils in our body from these ancient retroviruses that we acquired through the hundreds of millions of years, because we were also exposed to previous pandemics. When we look at 400 million years, and the retroviruses that are in our genomes, we know that there have been pandemics before, because these viruses are in our genomes. So these retroviruses that are in our genomes have made modern retroviruses like HIV able to evade our immune system, our immune surveillance. And so it's very hard. So that's our first problem, is that HIV invades the immune surveillance. We don't know exactly what to do when we're making a vaccine. What are the correlates of protection? We know that we need high neutralizing antibodies, and we struggle to get good neutralizing antibodies. The structure of the virus, the envelope structure, outermost structure, is a complex structure. It's forever changing, and the areas that don't change are hidden by glycan shields. So it's one of the biggest challenges that face the modern world is how to find an effective HIV vaccine. But there have been lots and lots of progress made in the last 10 years. We've been able to visualize the envelope structure with crystallography. We can see, where the variable loops are. There's some ideas about building scaffolds and making, immunogens to the various parts of the envelope structure. So there's a lot of movement in vaccine discovery, and this has to be coupled with the ability to access vaccine platforms to rapidly put your ideas into a vaccine platform like mRNA to test your hypothesis. And I guess this is where the stumbling block is at the moment. So there's a lot of ideas about these epitopes we have to target, but at a global level, there's a shortage of our ability to make clinical grade material because of the shortage of companies that are making mRNA. And in Africa, there's no country that is making mRNA vaccines, so we can't even piggyback on that. So at a global level, there's a failure of vaccine platforms and a failure for us to be able to put our good ideas into these platforms and test them in the preclinical or in the clinical model. So that's the kind of work that I'm working on at the moment. I'm part of this program called, we have a USAID funded program called the Brilliant Consortium, and it's galvanizing African scientists to discover these immunogens through breakthrough infections, and then to test these immunogens in the preclinical and the clinical model using the mRNA technology or self-amplifying technology or nanoparticles. So so although we were able to make all of these platforms in the lab, moving it into manufacturing is on the African continent is a huge problem. And so at this moment in time, my job is to try and raise awareness around the lack of vaccine manufacturing capability on the continent, use other countries like Brazil, India, and the US to help us make the vaccines in the meanwhile, but to try and make sure that on the African continent we have the technology developed so that we can make our own vaccines to test in a fast manner. Because if we're using global partners, then you have to get in a queue and wait for 18 months. So we're always behind we're always playing catch up. So part of this program, is to get involved in HIV vaccine discovery as a continent, and to move the needle on so that we can eventually have these vaccines manufactured in Africa as well as test them. So it's a very exciting program, but it's the scientists are clever. They've got great ideas, and we're very good in the laboratory. But at this moment in time, there are hurdles from getting our concepts from the preclinical into the clinic because of this global manufacturing failure to make clinical lots of vaccines for anything, whether it's TB or Mpox or HIV. We face the same kind of problems. About the problems we face in Africa with Mpox at the moment. We have another epidemic, and there's a global vaccine shortage, and there's no one making Mpox vaccine on the African continent. And the closest we'll get to making an Mpox vaccine on the continent is around 18 months' time. And so we also have to rethink, so a lot of vaccine R&D is also to rethink the parameters around how vaccines, what is the procurement, what are the trade barriers to vaccines at a global level, and what prohibits Africa becoming an important player. So you can see science and politics and economics always play together. And we have to, when you are a scientist, you also are confronted with the kind of barriers that impede you. For example, another barrier is that when we do clinical research and laboratory research in Africa, our reagents that we have to bring into Africa cost double than what you could do to buy them in the United States. So American scientists are better off because their reagents are cheaper and we pay double. And it just is an unfair way. How do you level those? The playing fields to make it fair for African scientists to be successful. So these kind of things you find out when you're doing this research. You're saying, well, if I was buying this reagent in America, how come it costs this much? Yeah, so a lot of the research that we do is also saying how unfair the system is and how African scientists are marginalized by not only the lack of infrastructure and equipment, but also just the sheer cost of doing the laboratory assays in Africa.
Yeah, you make me remember a time when I was still an undergraduate student, and there was another student in my residence who was also a doctor, who came up to the dining hall and said, politics is sort of the highest form of science. And me being, an engineering student, I got angry. I was like, what do you mean about this? But then, he managed to convince me that, politics sort of does gatekeep even what science is even possible to conduct in a society. What do you think needs to be done then? Because I think, it's quite shocking that really in the entire African continent, we don't have companies that, make these vaccines you need. What needs to be done? Is it, and also, including the problem of buying, the same ingredients you need at twice the price you would need in the US. What needs to be done? Is it a matter of we don't have the money to, invest in this capacity? Or is it a political thing? Or do we lack the technical know-how and the skills? What do we need?
So I think it's threefold. So I think the first thing is political will. So at a country level, at a AU level, and at a continent level, we need the politicians to be aligned in the vision of doing manufacturing in Africa. So there's a political will, and with political will comes funding. And so if you look at the successful countries like Brazil, there's a state-owned vaccine company. The state buys, it secures the volumes of the vaccine. They say, whatever vaccines you make, we will buy. We don't have any tenders. The State Vaccine Institute makes the vaccines. The government buys it from the institute, and the institute then can be able to be a going concern. So we need government investment in science and in manufacturing. And at a continent level, African countries haven't invested as much money as, say, the NIH or the US or Europe or the UK. So we have to see how important science is for our GDP. So we have to understand that without science, we're never going to be rich, and start to put money into science. So we need the politicians to understand the role of science in driving the GDP of an economy, and invest in state-owned entities and and guaranteeing the volume. Third, we need to understand the trade barriers that affect African manufacturers. And so what we need to do, we need to make sure that you should not be able to purchase a vaccine for cheaper in India than for Africa. So we have to look at the prices. So we have to make sure that we reduce the tariffs on importing reagents and ingredients to make vaccines or to test. So we need to reduce the tariffs to make it cheaper to bring in the ingredients, and we need to increase the tariffs of imports of vaccines. And so therefore you're guaranteed a local market. You also have to make sure that African manufacturers are guaranteed volumes. So basically, the African countries have to say we will only buy 60% of our vaccines from African manufacturers. So African manufacturers had to be guaranteed a market, and then we need to pool procurement at a continental level, and then we also need access to the international market. It's not just why should we why does Africa seen as a country, a continent of consumers, and everyone else can bring their products to us. Why can't we sell our products at the international level? And so what we also need to see is the global procurement of vaccines changing. We need to see Gavi, UNICEF, UNICEF, Global Fund buying African vaccines for global distribution. And so the dynamics of global share and volumes needs to change. And so we as a bloc in Africa, we have to restrict trade, we have to impose tariffs on vaccines coming from other countries, and we have to guarantee volumes for our manufacturers. And until charity begins at home. Yeah. So we have to start caring about our own continent before we care about other continents, and we have to find a way. And and the third thing is that we do have an issue with capacity. So we have to build the capacity to make good products, and we need engineers, we need GMP engineers, we need biomedical engineers. We need people that can help us run these manufacturing plants so we can create high quality vaccines. So it needs a shift, a political shift, a funding shift, and a shift in the trade, the barriers we see in trade. So it's an economic shift, a political shift, as well as much as a science shift.
Yeah. So I was already a university student when I understood really what it meant for someone, who's HIV positive to be undetectable, and what that meant for their ability to either, to infect or not to infect others, sexually, that is. But, I remember when I was in high school, I already understood very well that malaria was spread by the female Anopheles mosquito, and I knew that it had long legs and all of that. So that made me feel like, my education had done very little to actually make me informed and really aware about HIV, which was strange to me given, that the history, we have with HIV as a country. Do you think that, as a country, we do enough education and awareness around HIV, and in particular, the education system in the country does enough?
Yeah, I mean, it's a hard thing because HIV is so stigmatized, and people are, because HIV is spread through sex, there's an immediate connotation that you're promiscuous if you've got HIV. And so there's a lot of shame and stigma and discrimination around people living with HIV. So that's what's made it hard. So it's hard to talk openly about your status around the coffee shop, around the at the office. People who are HIV or living with HIV don't tell anyone that they are living with HIV, and that kind of creates the whole silence around. It's a silent epidemic. So that's our first issue. It's the way we deal with stigma and discrimination, and and then our second issue is sometimes it's hard to talk about how to not get HIV because of the socio-political factors that give you HIV. So we have a patriarchal society. Women find it difficult to negotiate safe sex. There's a lot of transactional sex, and there's a lot of intergenerational sex. And so there's a lot of stuff that it's very hard to change at a societal level that will empower women to navigate using a condom or being on PrEP. And so I guess we have to also address the kind of socio-political things that make it hard for us to have these discussions, make it hard for, you to talk about sex and your vulnerability. And so I think it's a complex, the society has to evolve more and we have to address all the issues around patriarchy, lack of power of women in relationships, and the kind of poverty that makes girls vulnerable to HIV, because they will transact sex for money to buy food, for education, for everything. So until we address poverty, it's also very hard to normalize HIV. So it's a complex thing. HIV prevention is very cold, whereas, the passion around sex is very hot. And so sometimes it's very hard. It's a hard thing to address. And so, that's why an HIV vaccine is a good thing, because, you have an HIV vaccine that's protecting you. And so the issues around navigating safe sex, feeling bad if you had unprotected sex, all of that will be taken away. And so if we could find things that were blameless, and that a woman wouldn't have to feel like they were blamed for getting HIV when they were just powerless.
Yeah, but that's a big issue, the one around stigma. And it was actually my next question, because I was going to ask, to what extent do you think that, the continued stigma around HIV and against people living with HIV, continues, contributing towards subverting the efforts, against HIV?
It does, it subverts our efforts, because, particularly in the health sector. So a lot of people who are living with HIV are shamed at the clinic, are treated badly, are outed when they're sick. They or when they're having their babies, they may be treated differently by the healthcare sector. So the healthcare sector is the biggest discriminator of people living with HIV, and that's why people don't want to go back. If you've been shamed by your clinic, you don't want to go back for medicine. You're embarrassed. And so we have to change the attitudes of healthcare workers, of the health sector, to support and encourage people living with HIV to be on treatment, to see them as partners in this endeavor to end AIDS. And, and maybe we have to start there. And then I guess at a societal level, that we have to have a better messaging and better information and better support, so that we all see this as a process to protect everyone, and and try and make sure everyone understands that you equals you, undetectable is untransmissible, and the only way we can get to you equals you is if everybody plays the game and takes responsibility for our country's HIV problem.
Yeah. So I think most of the people who are my audience in this channel are young people, and some of them are actually working within the healthcare sector, and some of them decide to come study abroad, like me, for example, to the UK. And they would like to know how do we as South Africans, maybe as the Medical Research Council, how do we incentivize South African researchers to build research ecosystems at home? That's one. And two, how do we support the production? I suppose you've spoken to this a bit, but how do we support the production of biotech and vaccine capacity at home, including owning the IP for such work? And the last one, what are some strategies to oppose, Irish and UK healthcare system poaching medical professionals from South Africa?
Yeah, so I guess one must think about brain circulation instead of the brain drain, and so we have to find ways of attracting people back into South Africa and into research areas, and that's also it's a political issue. We have to make sure that our governments are funding science. So South Africa is much easier than the rest of Africa, because we do have the National Research Foundation, we have the Medical Research MRC, and we also have the universities that have an interest in PhD and postdocs to create that research intensive environment to drive innovation forward. So there are opportunities to get local funding for research in South Africa. But also, if you are based in South Africa, there's lots of opportunities to get foreign funding. So there's the NIH funding, there's the EU funding, there's EDCTP funding, there's the British, there's the Wellcome Fund, and the Gates Foundation. So internal funding in South Africa is there, and there's also a global network of funders of research, which you need to tap into. So that should not, if you've got a good idea, there should be no reason why you can't do it in South Africa. So that's the first thing, that there are opportunities both internationally and nationally if you have the vision to come back. The second thing is, I mentioned about brain circulation. And so even if you are not in South Africa, you can create opportunities. You can, create a perturbation of activities. So you sitting in Oxford, you and I have met me. You meet someone who says, "Oh, I've got this cancer treatment." You connect me, and basically opportunities are shared. So this thing about brain circulation and spreading the goodwill around and creating networking and collaboration is important to try and keep the brain circulation going. And that's an important thing. And the ecosystem, we exist in South Africa in the microcosm, but we're also on the African continent, and we're in the world. And so we should find ways of networking to improve opportunities for everybody, and to create this kind of ecosystem that is vibrant. How do we stop people from leaving the countries? We have to create a situation in our country where the environment where they work is safe. So people need to be paid. They need to be paid properly. They need to work in an environment that's safe. And they need to work in an environment that is conducive to enjoying your job, and they will need to be paid properly. So until we address the working conditions of nurses, the pay conditions, I'm sure you've heard about all the infrastructure challenges at Helen Joseph Hospital. So we have to really we have to make sure that our health system gets fixed, and that we give nurses and doctors and OTs and other allied healthcare workers the dignity of a safe and beautiful space to work. And then we also need to create a hospital infrastructure that gives patients dignity as well, that they don't need to be starved or wait for their operation. So we have to create a better health system that needs to happen. And then I guess, people leave the country because they're scared for the safety of their children or themselves. And so we also have to create a safer environment for South Africans and to stop them from leaving the country.
Yeah. My last question. So given all the work that you've done in healthcare activism, the scientific research, the clinical work, and the leadership work you've done, so what are you most proud of? And two, what do you still hope to get done in the decades of work still left within you?
I'm proud of being a clinical researcher, because I believe that's the quickest way for me to change, to make impact and change people's lives. And so I've been fortunate in the work that I've done in the HIV field, has directly related and translated into lives saved, whether that was in the PMTCT arena or in people on treatment. And so I think that's what I'm proud of, is the work that I'm doing is able to change policy and lives. What am I looking forward to? I'm looking forward to contributing to making an HIV vaccine. I'm looking forward to seeing vaccine manufacturing flourish in Africa, and I'm looking forward to, continue to combine science with activism and to highlight the issues that we face. So they may not be, it's about the situation that Africans find themselves in, seen as a continent of consumers, and a continent that's been largely have extraction, and and to try and change that mindset, which is true decolonization, is to make sure that we change that center of gravity to an Africa that sets the agenda on trade, and becomes prosperous because it focuses on the continent and not always being a continent of consumerism and extraction.
Yeah. Well, Professor Glenda Gray, thank you so much for making time to talk to us here. I really enjoyed having this conversation with you, and I'm sure my viewership will equally enjoy it. And yeah, thank you so much. Hope to talk to you again in future.
Thank you. We spoke a lot about the science of politics and not so much about the science. But I hope it kind of gives the kind of the view of why science is important. So thank you.
All right. Thank you.
Bye.
I would have failed to fulfill my duties as a YouTuber if I didn't ask you to smash that subscribe button, like this video, leave your comments about what you think about this video down in the comment section below, and finally, share this video with anyone you think might like, enjoy, or benefit from this video. Cheers.